So I think we're about ready to start our second session. I'm going to introduce the first husband-wife combo to speak. Doctors Jenny and Bruce Southard. They are going to present crash, pop, snap, what not to miss and what to do. Dr. Drew Southard attended medical school at the University of Colorado and completed residency training in emergency medicine at the University of New Mexico. He works for Vituity in the ER, the trauma center at St. Al's, and serves as president of the St. Al's medical staff. In 2021, Andrew became a commissioned officer in the United States Public Health Service, where he serves as chief medical officer for BLM's Fire and Aviation Operational Medical Support.
Good job.
Well, for minutes, Dr. Southern worked as a wildland firefighter, EMTB. I don't know what the B stands for.
Basic, very basic. Yeah.
And wilderness guide throughout the West and Alaska. Dr. Jenny Southard also attended medical school at the University of Colorado and completed residency training in family medicine at the University of New Mexico. She went on to complete a sports medicine fellowship, and her interest in musculoskeletal medicine started when she was a Division I track and field athlete running at Madison Square Gardens, penny relays, and lettering all 4 years. She worked for St. Al's Family Medicine in Boise and loves keeping out the daughters and husband. Again, they'll present Idaho Lifestyle Injuries, crash, pop, snap, what to not miss and what to do from the vantage of their specialties.
Thank you, Becky. Gotta get a mic's working okay? All right. So thank you for that. So yes, Ginny and I have been married for a while now, I think 16 years, and we did meet in medical school. We did share a dead body. We were anatomy lab partners, and we did couples match. So it does happen, and it does work out. So, and as an ER doctor, I do work at the trauma center. I appreciate all of you here. I never want to miss an opportunity to say thank you for taking our calls in the middle of the night. I promise we don't love to wake everyone up, but I appreciate what you do for the community because I get to see them in the ER, and we really do rely on not only specialists, but our family practice doctors and providers to take care of our patients after we send them home. So I appreciate that. Today we're going to talk about Idaho Lifestyle Injuries, and I just have to say one thing. I do work for the government, so I have to obligated to put a slide up there that says I'm not representing the government, and what I can and cannot say is not reflective of what the government believes. So that's about it. Jenny doesn't have any. Today the objectives.
So we have to stand close together, mic-wise, but we do like each other, but we'll be close, just so that Zoom folks can also hear. We were tasked with talking about what would be common injuries for people who live in Idaho and are active. So we have 3 separate things in here of our own personal injuries being outdoors. And this is kind of a combo of emergency medicine, wilderness medicine, sports medicine, practical tools that we thought you may encounter and that would be super helpful. So we'll try to go over, the injuries, what to do, and then how to follow up. Really, with the ideal being that you could be a doctor that everyone wants you to be and look like a hero.
So I know probably everyone's had this expression or this question or hey, we have someone with us, right? You're on a God hope not an airplane. That's my least favorite. But you're out and with your family and friends, and you just hear this like, oh, well, so and so is a doctor or a nurse practitioner, and you're like, the hair on the back of the neck starts to stand up, and you're like thinking, oh my gosh. So fortunately, as an ER doctor, I think that's kind of what we do. But this is the way that I look at this, and we'll talk about it. But quick, I just identify A, is it life and limb, right? I mean, that's what I spend a lot of time training and doing. The really bad things, those are fairly obvious. That's not actually what we're going to talk too much about. But B, there's a subgroup of injuries here, and it's these little things like, I can fix something like this in the backcountry wilderness with some basic tools that I could actually carry, and because I'm a clinician, And those are the really important ones. And then there's like the ones that really won't matter. Most of dermatology falls into this category in the wilderness, but there are some rashes and stuff like that. And this is the target. And what I call it is the Fix-A-Flat, right? So anyone ever use Fix-A-Flat? This stuff is amazing. You put it in your tire, you're out in the wilderness, and instead of having to change the tire or cancel your trip or get a tow truck and ruin the whole day, you get out the little bottle, you squeeze it in, the tire inflates, and you keep going. And so those are the things we're going to talk about here today. So we'll start off with something a little bit easy. This is a 35-ish-year-old person. They're backcountry skiing. I assume a lot of us have done something like this, but now they're saying, gosh, I can't put any weight on my foot because my big toe hurts so bad after we've been backcountry skiing. This has happened to most of us probably in this room to some degree. You've all had one of these. And I have seen, in my other job, I teach tough as nails, hot shot, smoke jumpers, people that do crazy things and undergo a crazy amount of stress, physiological and mental, to do things. And this will stop them. And what is it? It's a quick, anyone know what that is? Subungual hematoma, right? So these are very common when you go hiking and all these sort of things, and you put pressure and micro trauma over the course of a couple hours. And if you've never had one of these on your toe, they hurt enough that you might not be able to walk out of there. So what do we do with them? There's a 50% rule. Okay, so if it's more than 50%, you can consider draining it. This isn't rocket science. I teach people who have no medical background to do this, but it really helps them. It's not life-saving, but it is pain relieving for sure. And what you're basically going to do is you need to get the blood out. Oh, you need to get the blood out of right there. Okay. And how many people have ever drained one of these before? Okay, good. So a lot of us, right? So how do you do it in the field? Well, there's a couple techniques. The one on the right is actually the one that I use most in the emergency department. I call it the drill technique. So you get a like 18 gauge or 20 gauge, whatever needle you got. You put it right on top and you just slowly spin it, okay? Now what you don't want to do is kind of what the picture's showing, is put weight on it, because that's what hurts. And people will be really like cognizant of that. If you put weight on it, they're like, because you're drilling with the needle right above the spot that hurts. But if you just do it, and it's kind of like when you used to do a fire starter, I don't know if anyone's done this, but you try and make fire with just like 2 sticks. That's what you want to do. You really start to drill and it starts to spin it down. You start getting some of the nail and it will cut and finally pop. But the other way to do it, which is probably more useful in the wilderness setting, is this. You get a hot poker, all right? And you basically, you keep one of these, and you get a lighter. And I think, let me hit this, there it goes. And this is what's going on here. So this is actually a buddy of mine. And
He's got one already.
they first try with a push pin. Now what's wrong with the push pin? Well, they heat it up and the plastic around it melts.
This handle is
So you can't get enough actual pressure on it. So being resourceful, they actually did have a paper clip. You start it, we'll see here in just one sec, I think. Yep. This is brought to you by Big Smoke. And the other important piece here is you see how they made the bend? That's important so you don't burn yourself. It's a heat sink, okay? And it takes about 3 seconds. Boop. And that makes it feel so much better right
Doesn't
there.
that feel good?
So-
That does feel pretty good.
And then this is the spot there when like, ooh, that's the money shot. All right.
All right, so you now have successfully put a hole in a nail and you're able to get out. And this is the same treatment if it's in your fingernail or in your toe, same procedure. And the idea is that you want to try to keep it clean and dry. You don't want to introduce infection. Unlike most musculoskeletal or other injuries where like a warm soak in water would be helpful, it's thought that this breaks down that fibrin and has a little bit increased risk of clotting, or not clot, of clot breakdown and infection if you soak for prolonged times. But really no risk of infection with just the trepanation. Observational study, regardless of size or the presence of a fracture, none of them had any infection. There's also a double-blind randomized controlled trial and 193, so this was more in a hospital setting. Those that had open fractures of that distal phalanx, if they were given antibiotics or no antibiotics, they had similar infection rates. The caveat being, if you're somewhere dirty, you can't get it clean, cephalosporin, 7 days, worth preventing infection. And then aftercare. So in the toe, there's like a 9 to 11% risk of fracture underlying that subungual hematoma. More commonly, mechanisms of injury. So crush, a mower, dropped a weight, not necessarily I've been hiking, I've been snowshoeing, my boots were tight, that type of injury. And in the hand, it's 32% also had distal laryngeal fractures. And then if it's less than 50%, the sub-study showed none of those are fractures. So you really need more than 50% to have a fracture in a finger. And if you suspect a fracture, you're just going to splint and extension, 3 to 4 weeks. They typically heal without any surgical intervention, just fine. The exception is in pediatrics. So Seymour fractures are Salter-Harris type 1 or 2 fractures, and those occur, further up, so that you can have tissue that goes into that physes of the finger. These are thought to be, more emergent, get out, get in to see a surgeon, in part because it has higher risk of osteomyelitis, mallet finger, complications. And all of these kids do require antibiotics. So, but you can see it looks a little bit different. It's higher up.
See the bird? I did that. That was cool, huh?
Yeah.
Yeah, that was my part.
And specifically, you have 0.28 relative risk reduction if you have fixation antibiotics within 48 hours. But if you do within 24 hours, you get a little bit better.
All right, so we're our next unfortunate victim here. This could have happened here to anyone, right? So you have a fall from skiing, and this is what the person shows up with, or you see them on the side of the slopes. What's this? Maybe what's over here? Maybe a dislocated shoulder. So actually, this is a hard one. I'll give you a look. So if you don't see a lot of these, this is actually a dislocated shoulder on the right. So the way you can tell, see how it nicely comes down nice and smooth on the right, and then over here, this is the step off. So this is a very common injury. How many people have had one of these before? Okay, hurts, right? They're not fun. So this is an anterior shoulder dislocation. This is something that we see a lot of, especially in active athletes that have some sort of, I would say, moderate force fall on an outstretched arm. And it's kind of the active Idaho lifestyle population, much more likely to dislocate than have a humeral fracture. And most of these are going to be anterior. Posterior shoulder dislocations are associated with 2 things, seizures and lightning. I've seen, I think, 2 in my career. You can also get them inferior and superior dislocations, which are super rare. We're not going to talk about those because hopefully you never see them. But this is why you see that sucking in. So it's called a vacuum phenomenon. But there's basically the gap where this humeral head was supposed to be. So that's how you can kind of tell. It's one of the key pieces in ruling out maybe a humeral head fracture as well. Obviously, you won't have an x-ray, but this is the x-rays we typically used to get. So in emergency medicine, it's always like, what is it and what could kill them? So for an injury like this, the first thing to assess, and these happen a lot on like mountain bike trails and stuff like that, or skiing, is going to be make sure nothing else is going on, right? If it's just a shoulder, that's fine. 50% of all dislocations are going to be shoulders, which is huge. And like we said, a lot of them are anterior. The ability to rule out the fracture is really dependent on 2 things, mechanism and age. So I wouldn't consider this really in your young pediatrics or people probably over the ages of 70. Those are a little bit harder for me to really say you don't have a fracture without an x-ray. But if you've got the right mechanism, it's pretty unlikely. The issue and why we teach this one to a lot of people is that these are super painful. They usually happen somewhere remote, and it's really hard to walk out on a trail or something like that for a couple hours with a dislocated shoulder. And if you can put it back in, that person's going to be able to walk out pretty easily, continue to what they're doing, and it really saves you a lot of time. So there's a couple of techniques. Actually, I should caveat. There's like 1,000 techniques to put a shoulder back in. Which means to me as an ER doctor, like there's 2 things. 1, orthopedic residents need to get papers published. And 2, if you just yank on it in a bunch of different ways, they usually go in. So that is emergency medicine and basically a quick phase. That being said, there's 2 techniques that I really like to teach people. The first one down here is it's called the Davos techniques. And Jenny can demonstrate it like a Vanna White. So this is something that they do themselves. And apparently, I didn't know this, but it's 96%. Oh, you stand. Yeah, 96% success rate if it's done within 10 minutes for people under 40. I don't know if it's quite that high, but what you're essentially doing is trying to get their shoulders back and they're putting this inline traction. And so you can have it do them themselves. If I did this in myself in the field, this is exactly what I would do, would be this one. You can actually, you can't see too well here, but they've actually tied their hands together. And it's not like mean, they're just like gonna be able to put some more weight on it there, or you can assist them down here. And it's just slow. And I will say the biggest thing about getting shoulders back in, when I trained, all we did was propofol and ketamine. That was like, you got a shoulder out, you're a resident, you're getting propofol and ketamine, and we're gonna move you. Since I would say this technique and the other one I'm gonna show you, the Cunningham technique has come out, I've sedated one person in probably the last 6 years for shoulders. So it can be done very easily. And I think that's been most of the people's experience in emergency medicine. The second one is called the Cunningham technique. And the Cunningham technique is, we'll demonstrate with Jenny. There are 2 videos up there. One is actually Dr. Cunningham himself. He's Australian, he's very nice to listen to. And if you get a chance, I'm not gonna show it now because there's a couple minutes, but it shows just how fast and how easy this goes in. The other is actually a cartoon view of this because it kind of demonstrates a few things that are easy to understand when you're not seeing a real patient. But the basis of it is, if Jenny's hurt this shoulder, how do they present? They present like this. What do they not want you to do? They don't want you to come up here and do this, right? Like move that. That's really what they're guarding. They're kind of guarding, and they usually are leaning in. And if you can get your patient to relax, when you're on the ski hill, whatever, say, hey, I'm just going to check a few things. I'm not going to do anything that hurts. Please, nice, deep, relax, breathe, get them calm. Most people, that won't hurt. If you can grab their elbow, I can do my little CMS check over here. And then I just make sure that their arm moves, blah, blah, blah. Okay, they've gained some trust. If you can get them to put their hand on your shoulder, just to this level, this takes a second. That actually hurts a little bit. So that's the first step. And I do this sitting down, but because you can't see this, we're going to stand up. Take your hand here. Put it on top, just the weight of your arm, and maybe like 5-10 pounds of pressure right there. And then you're gonna say, go ahead and sit up tall, nice and tall, and I touch their back, nice and tall. You get them, that brings their shoulders back into line, and kind of opens up their scapula. And you have to tell them that several times. 1, 2, 3. Okay, all I'm gonna do is I want you to nice breathe, and I'm gonna massage a few things here. You start up here, the trapezius, and you massage maybe 3 to 5 seconds. Kind of like they describe it as a warm kneading of dough. So you just kind of squeeze, squeeze, squeeze. Move over the deltoid, 1, 2, 5 or 6 seconds here into the biceps. And you're just kind of putting a little bit of subtle pressure here. Once they relax and you say, sit up, sit up, sit up, you do this maybe 3 or 4 times, about 80% of the shoulders will go back in. It looks ridiculously easy. It is super fast. And watch the videos because it's amazing how many times this occurs. And the person's like, did you feel any pain? And they're like, no, not really. The shoulder wants to go back into that home. And so once you get the muscles relaxed and anatomically in the correct position, it'll go in and you'll look like a hero for doing it in the field. Oops.
All right, so after it's back in, they're still going to have some discomfort. And so the most important is getting them in a neutral position that's going to provide some relief. And the duration of slinging really depends on age, in part because this is the highest risk of reoccurrence. So the older you are, the more likely that it's a one and done trauma. Whereas if you're younger, you really have a higher risk of shoulder instability. So if you're older, you've got 1 week, it's going to stay in its place. Whereas if you are younger, it really, you're going to probably need a surgery or further evaluation. The X-ray is non-emergent. So of people who have an anterior dislocation, about a quarter of them have a clinically significant fracture. There have been several studies that show if you are over 40, first-time dislocator or a traumatic mechanism, then you need an X-ray. But if all 3 of those were absent, then there's a 96% that you don't need an X-ray because 96% of those folks are not going to have a fracture at all. So in this, we have, that's actually Drew. If you're in the field, have a shirt.
Oh, you can't walk away from me.
Just tuck in, but that can provide some help for slinging if you don't have any. This is, kind of the awkward
Triangle bandage.
Yeah. And we'll show another option later. So the clinically significant fractures, what are those? Those are really these 3. A Hill-Sachs deformity, it's actually a compression fracture in that distal femoral head. Shown here. And if it's over 20%, then it needs a surgery. And about 35 to 40% of anterior shoulder dislocations do end up with this Hill-Sachs deformity. The Bankert lesion is actually when you avulse this anterior part of your labrum. And this is, I think, like 90% are considered soft tissue. So it's just the labrum that's disrupted. And then 5%, you also avulse some of the bone. And then there's really been a move more for arthroscopic repair for these, in part because just higher risk of instability if it's not treated surgically.
And so after you reduce someone, the nice thing is to put them in something so they're not flopping around. This can be done in a lot of variety of different ways. If anyone does wilderness medicine, the one I actually teach for our firefighters because they wear yellow shirts is that if you need to just put it in, you can button your shirt around it or button the collar around there. It provides a really quick sling. There's also a lot of other wraps and such you can get creative with. So there is some axillary nerve damage. Very rare. I haven't seen it too often, but you can check that. And then obviously the younger you are, the more likely are repeat. How many people have had repeated shoulder dislocations? Yeah. So you'll see it if you have it at a young age. Sometimes people are like, hey, will you pull on my arm because it's out again? That's how bad it can be. So, all right. So we got a 65-year-old male that falls rafting into a hole and comes out like this. These are actually pretty common. So this is obviously not correct over here. That's the area, in case you're wondering. And this can happen to most of the digits. I mean, these are common. I put one back in Thursday on my shift. These, surprisingly, after people get done like freaking out and feeling like they want to throw up because their fingers turn the other way, they aren't that painful when they're just sitting there. But when you manipulate them, of course, they are. These are pretty, I wouldn't say easy to put back in, but they are not real rocket science. You just got to pull on that thing, okay? And the way that you pull on it, you want to kind of recreate the injury and put it back on. And I think about stacking two sticks on top of each other. If you have, and we'll talk about this a little bit more, you can do a little digital block. How many people here do digital blocks or use lidocaine? Okay, so good. That's one of the few things, we'll talk about the things I carry in the background. I carry a suture kit and some lidocaine because you can use that for a lot of things. And the digital block is really nice in this situation. It does numb it up. And if you've never done one, I promise you, if you went to any sort of medical training, you could learn to do one in about 30 seconds. I just go in, I hold the finger, the nerves run here. I put the needle in, I hit the bone, I back up, I put a cc of fluid in, I go to the other side, I go in, hit the bone, I back up, I hit a cc of fluid. If it doesn't work, I do it again. It seems to work most times. So that's pretty easy. And if you can do ring block and all this sort of stuff, but it really does work. The one thing I will say is it takes about maybe 10 minutes to really get anesthesia. People are a little quick to rush it. There's some great videos online if you want to see it. So I just want to point out one piece here, and this is why it's kind of important to pull. So your little digits have these kind of ridges. If you don't, when you do this, you want to pull and then stack it back on. Because otherwise you kind of grade it over these things and it just takes more time. And about 10% of the time you can't get it back in. And that's because there's some sort of capsule or some piece of ligament in there. And that actually needs a hand surgeon to go in, open the joint and open it up. It takes them like 20 minutes, but it's nothing that I've ever done. So you may have an open fracture too. That's not super uncommon. And if it is open, just irrigate the crud out of it and then reduce it, put on antibiotics and splint it. And the best way to splint them is just through buddy tape like this. So nothing really amazing here. Long-term, these are somewhat tricky injuries. They tend to have some arthritis and pain for quite a while. And I would say, even though it's a fast injury to reduce, it's not a fast injury to heal from. We usually do like to get people x-rays at some point because a lot of them are associated with small fractures and they will follow and manage those. So fortunately, this is my dad. He's actually in the back of the room right now. But this was same injury. That actual injury happened on the Salmon River as we pushed off of the boat for a 7-day trip. And we were able to reduce it like on the dock and save a 7-day trip. And like, this is just the point. It doesn't have to be fancy, right? This is literally duct tape. So duct tape, ibuprofen, and a few beers, and he was good to go for a week on the Salmon River in a wilderness setting. So. All right, so this is a 30-year-old who's running on the trails. This is the other one I teach all the firefighters and medics and stuff like this because this is common. And they have this. So Anyone seeing this or had this happen to them? Okay. So this is not a dislocated knee, correct? This is a patella, right? So lay people will say, I dislocated my knee. Knee dislocations are real bad and take a lot of force and associated with real bad vascular injuries. So even though they'll say I dislocated my knee, they probably mean the patella if they're talking to you. So this is the patella. This is a very painful injury. People will come in, and we probably can't demonstrate it, but they come in flexed, all right? Or come in flexed, or they're laying on the side of the trail flexed, I should say, because you can't walk. The patella kind of locks it out, and it ends up over here on the lateral aspect of it. I think 80 or 90% are lateral. There is some medial, but medial's not very common and more associated with other injuries themselves. There is not a lot of rocket science to putting this one back in either. You have to grip it and flip it up and straighten the leg. I would say 20 to 30% of the people that I have seen in the emergency department actually self-reduced because it's so painful. They get up and they like jump, and by kind of straightening that leg, they actually slip the patella back in. I've had some poor people that actually like did that and they put weight on it again and it popped out again the second time. So yeah, that's pretty bad. But there is a quick way to do it, and that
And Joe, and some caveats too, is that the more you can relax, just like the shoulder, the more success you have going in. So the best way to relax those quads and hamstrings is to actually have, your patient laying flat. So getting supine, so we'll demonstrate that.
And if they're flat and supine and you have your hands on the patella and you're just going to literally flip it over. When you do that, if you can have an assistant, and I know most of you can't see this, but she's going to go getting real crazy here. So they're going to be flexed like this. Literally, if you can just have someone hold the bottom of the ankle down here and let the weight, and then as you flip it, you just straighten the leg. And that little move there will help get it back in quite a bit better. In the emergency part, if I can't get someone's in, I usually sedate them. And my trick is I have the lowest trained person around, the lowest tech. I give them a whack of propofol and I have the tech hold up the big toe. And just by the weight of the big toe, their leg goes, that kind of hyperflexes and the patella comes back in. I don't even touch the patella. It's a neat little trick we do in emergency medicine when people are asleep. But it's kind of like that is, I use that as a demonstration because if you can get the straighter you get that leg, the easier you'll get to pop that over. There's an embedded video for you guys eventually to look at that too. And pretty easy to do.
So most of this occurs in terms of athletes and either dancers or in runners, traditionally going downhill where you have a pivot or a turn that's unexpected for it to dislocate. We try to, wrap it so you could use, a t-shirt, a jacket, something to get you off wherever you are. And then trying to be non-weight bearing for those first 2 to 3 days typically helps with pain. If you were seen in my clinic, we would put you in a knee immobilizer, typically just for, 7 days for follow-up. And then x-rays, they're not typically associated with fractures. So no x-ray is typically not needed unless at that follow-up they're not showing function or they're having significantly more pain or you suspected another injury because they had a fall with the dislocation. Return to play is 4 to 6 weeks later, and better if you can get in with some aggressive physical therapy. And then children, they have a 70% recurrence rate. In part, it depends on your Q angle. If you remember, that's the measurement from your ASIS down to your patella versus patella into the ischial spine. So, and especially more in women, we have larger Q angles in men, more prone. And treated operatively versus non-operatively, they tend to do the same in terms of outcome, 67 versus 71%. So we try to treat it non-operatively if possible.
All right. So sublingual hematomas, 3 common dislocations that you could put back in the backcountry that would then really help out your fellow family member or friend. This is another one that's very common. I say a lot of mountain bike accidents. So this is hard to see right now with the sun, but comes in with some, not shoulder pain, but pain right here. So had a fall, fall out, search hands. What's it going to have? Probably a clavicle, right? So these are common. Guess what? They hurt pretty good. I mean, I'm sure some people in this room have broken their clavicles. From my standpoint and the ER and like what I would look at for someone who's in the backcountry that just went off their handlebars is the other injuries, right? And so I don't know how many pounds of force it takes to break a clavicle. I'm sure someone's done a study on it, but I can tell you this: if you got enough pounds of force to break the clavicle, you can have a pneumothorax or a rib fractures and those things. And so you probably have had patients follow up with us from the ER, and a lot of times they won't have clavicle films. And the reason why is because I can see the clavicle on an AP chest and a lateral chest. I can't see the lungs on the clavicle aspects of it. For the most part, this is all the information that at least we need acutely. And for the most part, probably all the patient's going to need to know. I'm sure there's some orthopedic surgeons in here that could tell us, when they need the clavicle films and those sort of things for operative planning and who to get operative on. But for the most part, if you're seeing this out and you think that there's only the clavicle fracture, you put them in a sling in the backcountry, really evaluate their lungs. And if you're comfortable that there's not a lung issue and there's no skin tinting and they're neurovascular intact, that's something that's going to be in a sling for many weeks, and you don't really have to worry too much else about anything.
This is another example of a hood of a jacket to be a sling. So you can be creative with what you have in the backcountry.
You can take that one.
So obviously, if you have breathing issues, like Drew said, we're worried about pneumothorax, rib fractures, or an open fracture, as well as this demonstrated skin tinting. That's, need to get out into the ER as soon as possible. Younger active athletes, also younger here is really anyone 40 and below. There's been a movement to treat these more operatively than non-operatively. About 70% of clavicle fractures in adults are in that middle third, and about 90% are in kids. Kids 10 and under typically don't displace at all. They remodel fast, they heal great. Kids 10 and over, they tend to be a little bit more displaced, but they still heal great with the remodeling. Adults, so once our physes are closed, we just don't heal as well. So there's a lot more functionality, return to work, return to activity with a quick orthopedic procedure for plating. Floating shoulder is really when you also have a fracture in your glenohumeral head, and that requires operative repair. There has been, lots of different orthopedic studies comparing different types of slings, swath, figure of 8, thinking that, if you hold it further back in a neutral position, you'll have better healing. The figure of 8 raise, though, is a little bit impractical because you can't adjust it yourself. You require others that are, constantly pulling your shoulders back. But typically 6 to 8 weeks or 6 to 12 weeks for adults and 3 to 6 weeks for pediatrics. The caveat being that shoulders and elbows get really stiff. So on day 3, you're having them, out of their sling. We're doing pendulum type activities, pronation, supination, so that you don't lose that elbow range of motion.
All right. So this rafting is a dangerous sport, and you have a 35-year-old guy and just takes the oar to the face, right? And so this was what they come in. They're on the side of the river, and you got this situation, and your decision right now is, well, am I going to fix this or are we going to not? That's pretty much it. And if you're not, what are you going to do? You're going to have them like hike out? I mean, is this something you're calling a helicopter for? How many people here suture on a regular basis? Okay. The interesting part about wounds, traumatic wounds, is everyone's, if they get a face, we get a lot of these referred to the ER because they don't want to, other specialties for urgent cares don't want to sew on the face. And that's okay. I mean, the reality is if I can do it, anyone else can pretty much do it as well, because the wound was traumatic. It wasn't made by like a plastic surgeon with a nice cut along the skin lines. The damage is done, and we're just trying to put it back together, essentially. So when you evaluate a wound like this in the backcountry, the decision to close it is probably the biggest decision. And I would say 99% of them, as long as they're not really, if it wasn't like a penetrating object or super, super dirty, they should be closed if you can. That's why I carry some suture gear. It's one of the few things that we as clinicians could do that most lay people can't. And even if you close it and it doesn't look great, that person could potentially get it redone later down the road. But 99% of the time, this never needs to happen. So the biggest thing is to get it clean. And there are a lot of studies that just more high volume irrigation rather than anything else. You don't need the bottles of normal saline. If you're carrying bottles of normal saline with you in the backcountry, go ahead and stop. You don't need them. So if you can drink it, for the most part, you can clean a wound with it, okay? The studies are actually really interesting about emergency rooms, and I'm not totally convinced this is the best about our profession, but basically they show that using tap water to clean wounds in the emergency part, just tap water, was equally as efficient as using normal saline or anything else. So it's more about the volume. The other thing they showed was using non-sterile gloves, no changes in outcome for infection in the emergency part. Now, either we suck at sterile procedures, which could be true, or these wounds are already contaminated, they're bad, and it's more just irrigating and then closing it. And I think that's probably the latter, is that the reality is, unlike the OR or someplace that's really sterile where you're doing these high-end procedures, I mean, you've put an oar through your face on a river. The gloves are not what's going to get you infected, right? So the other part you can do, and if anyone has ever did some wilderness medicine training, they always come up with like cool little things, but this is just an irrigation bag. So I would just take my analogy and pour it over the wound and get it clean. But you can also use some sort of plastic bag, Ziploc, whatever, just poke a little hole in it. I did this just for fun in my yard. And you can get like a 15-foot stream out of there. So I don't know what that PSI is, but it seems like enough to clean a wound. And I would just say the exploration is the big piece of this. So a few tips and tricks for suturing in the field. If you have a blood pressure cuff, which you may or may not, they can be used as a tourniquet. And trying to get a wound not bleeding when you close it is really nice. So if you have a blood pressure cuff that works. The other thing is, a common place to get cut is on the fingers with knives, and we stick our fingers everywhere and they get cut. And they bleed a lot, especially because people are like, "Oh, it hurts." They're holding it down. The blood flow is going there. It's bleeding all over. You have no idea what you're sewing. So you can just make a little tourniquet. And this is a great little technique. It doesn't have to be anything. You can take the tip of a glove, tie it around, do whatever you want. Make a tourniquet as you're cleaning that wound. It makes your life much, much easier. You do that with a digital block, and you're going to be a total hero if you sew up their finger. The regional blocks, so a digital block like we talked about, those are really good ones. If you're going to know of 3 blocks, I'd say the digital block is one, and then this is the other. There's 3 other facial blocks you can do. And the reason I like these, and I think they're important, is one, facial wounds, if you inject a bunch of lidocaine or numbing medicine into them, you distort the skin tissues, and it makes it harder to sew. They're probably already bruised and all beat up because of that. But the more you inject in there, it's also painful to keep injecting in that same spot. And the other thing is basically, if you can get that whole side of that face numb, it lasts for quite a long time with a small amount of anesthesia. So 1 or 2 cc's of lidocaine, which is about what I carry when I go in the backcountry. So if you haven't done them, if you just take your finger and you find that little spot right here where it hurts the most to press, like when you get a tension headache because you've been looking at the EMR for too long, you just squeeze right there. That's the supraorbital nerve. So you go in and you put a bunch of lidocaine around there, and it's going to knock out the whole half the forehead. Works really, really well. The other one that's pretty easy is if you go and you find your first canine on the lower part of the jaw, that sharp little tooth that's kind of pointing up like the canine, like a wolf. Just below that, you just go in right where the lip meets the tissue, shove it down about 1 centimeter, put a bunch of lidocaine in there, and you can actually feel that one sometimes. It's on your chin. If you press real hard, it's where it hurts the most. That one will get the lower lip as well as the side of the face. So that one's really quite nice. The one that I think is probably technically the most challenging, but not that hard, is this infraorbital nerve right here. And if you just take your finger and you press on kind of the bony prominence there where it hurts the most right here, that's where that nerve comes out. And technically, the way you do that is you pull up the lip and you inject up inside, which sounds bad. I mean, and so but you can just go straight in too. It just leaves a little, like you just poke a hole right there. It's just below the eye, so it kind of gets people a little nervous, but you can see it start to expand. The nice part is that gets the upper lip and this whole side of the face. And so the gentleman that you saw there was my buddy on a raft trip that took that, and that's all we did. We put a cc of lidocaine right there, gave him 15 minutes. We were able to sew that all up. The quick tip for sewing up lips is if it goes through the vermilion border, it's cosmetically a little more challenging. You just try and line it up as best as you can. That's it. The last thing I would say about in the field, wounds in the field, I generally wouldn't recommend putting deep sutures in. You just don't really necessarily need them. They are an itis for infection. And most times the wounds that we should be closing or could close in the field aren't something where we really want to put tendon and stuff back. People ask what suture I take. I take 4-0. 4-0 Proline is like a generic, it's a non-absorbable, and it's big enough that I can use it to really get and pull tension on if I need it, but it's small enough that I can put it in the face. Is it the perfect for all of those? Nope, but it is kind of the one if I'm going to take one or two. And then the last thing, this is unfortunate, was our daughter who got run over by a ski a few weeks ago. And if you see in her hand, see, it's a good sterile procedure here in the bathroom. If you look, there's some white stuff, right? So my rule, if I see white stuff, is they get Keflix. What is white stuff? Bone capsule, bone, tendon, anything like that. So those guys should get some antibiotics. Actually, most other wounds do really, really well, especially facial wounds that almost never need any sort of antibiotics in emergency medicine in practice. All right.
Another, potential is dental injuries, and you want to hold by the tooth part, not where you'd be chewing on food, not by the root. The quicker you can get it in, the better the outcome. You can use saliva, you can use saline. If you have to move it, saliva is just as good as milk. And then if you can get it in within 30 minutes, 90% of teeth survive. But if you wait over 2 hours, it's less than 5%. So try to get it in as quick as you can. You don't even have to get it straight. And after it's in, you can bite down on a piece of gauze, on a shirt, on whatever you have, just to try to hold it into place for moving forward.
Yeah, and no one looks like this after they got their tooth knocked out. I don't know, this is so, but the big thing is not to scrub the tooth. Probably if everyone's not or been taught, that's where all I forget the actual layer of cells on there, but if you scrub it, then you actually kill it. So you put it in there, and this is another reason to have suture. So if you were able to shove the tooth back in there, it's really loose, and so you can actually do a little tie around the other teeth or
buddy tape.
a buddy tape. Yeah, buddy tape the tooth. It sounds weird. It actually works depending on the gaps in their teeth. Works pretty well. But dental implants are like, I don't know how much, a lot, like a lot of money. So if you can put this back in, it'll actually really save them quite a bit of money in the future. This happens at like a lot of kids' games. So with kids, the important question to ask though is the primary tooth, right? Because if it is, who cares? Don't worry about it. But if it's not, then you want to replace it. All right. So one more kind of interesting injury here. So this person falls on the slopes and they are knocked out, or they are at your rafting camp and they fall, hit their head on a rock and get knocked out. So the question is basically, what do you do, and who needs a CAT scan? Who do you need to send out for these sort of things, right? There are a lot of, in emergency medicine, there's quite a few tools and things to decide who needs head CTs in kids and adults, etc. I'll break it down into like the really quick thing. If someone's got can't get over their headache, if they're consistently vomiting, or if they have any seizures, that's like real bad. I don't think anyone's going to miss that. Okay, there's something going on intracranially. The other one would be kind of older folks. So after the age of about 70, 80, that brain shrinks down, your bridging veins get bigger. And I can tell you, the smallest amount of trauma, I'm sometimes surprised at what sort of bleeds we see. And then anticoagulation. So if more and more people are getting on anticoagulants for all sorts of good reasons, but if you hit your head on an anticoagulant, man, those people bleed. So definitive, I would say recommending to come and see us at the ER, and this is going to be a common thing for a lot of you in primary care, or if you're at urgent care, who are you going to send? Those are some underlying things. The other things would be any sort of cervical injury. Midline cervical pain is obviously a big deal. And then some of these other things here I think are probably kind of no-brainers. Whether or not you have to send an orbital fracture to the ER, most people probably would. Honestly, we don't do too much with them if their vision is intact. They usually heal on their own. But if you've got concern for those, certainly send them in earlier. I wouldn't keep someone out in the field that was anticoagulated, having persistent vomiting, those sort of things. But most of these don't, and so they're going to have a bad headache, probably shouldn't be drinking alcohol that week while they're out doing whatever sport they're doing, and a few other things that Jenny deals with in her clinic.
And the photo there was the eye emergency, so hyphema, so totally different than a conjunctival hematoma, but when it's in that anterior chamber, that's need to be in with ophtho ASAP, so get them in. Concussion treatment really has not changed much. We're still using the SCAT-5, which was from 2017 consensus agreement. You can get it online. It's, 5-page document. It goes through, different neurocog testing, and, rest, but that hasn't changed much. What has come out, or what's new, is the University of Michigan published last year, 2023, a study of 1,200 Division I collegiate athletes over 30 universities with the idea of getting them back to exercise sooner, which is 2 slides. I'll go to this one first. So they had this Buffalo Bruce protocol where they'd have the athletes start exercising 48 hours after their injury. They start on a treadmill, they walk at 3.3 miles an hour, and they just continue to increase the elevation until they have a worsening of their symptoms on a scale 8 to 10 out of 10. And then they'd have them stop. And then they had them go 80% of that 5 days a week, just light walking exercise. Granted, this is in Division I athletes, and this is an observed, you're with your physician in the protocol. But if you are on the exercise, they recovered significantly faster. So about half time is their cohorts who delayed. They also had a lower incidence of long-term concussion. So this is kind of still in a research stage, but it's really the only new, since 2017, real updates. What can you do back in the field? Put on sunglasses, put in earplugs if you have them, if you're, several days from getting out, avoid the, noise, the light, and Tylenol. Still trying to avoid any anti-inflammatories is the main. So return and recovery, it's still individualized. Adults recover much faster than kids. And we're still, careful with kids, holding them out of, school and activities and athletics, and still obviously no return on that first day. And then there's that University of Michigan study. The return to play is still the same. Those 5 steps that you do each 48 or 24 hours, provided that there's no symptom change. That hasn't really changed, so we'll keep moving on.
All right, so those are some common injuries of your friends and family you'll get to experience in the Idaho active lifestyle. This is probably something else that you get asked or maybe have questions about, is like, what sort of first aid kit do you bring, right? I mean, you're the medical person on the trip. You're expected to have a first aid kit. I mean, and it's going to be awesome. And people are going to be amazed by what you carry. And I tell you, I don't carry much. So the difference between luxury and utilitarian is that luxury has one use and a utilitarian has more than 2. So when I make decisions about what I'm bringing for different activities, that's one of the things is what can I use something for multiple things for? So like a bottle of lidocaine, it's great for numbing for wounds. I can also use digital blocks, regional blocks. I could potentially do an intra-articular block if I had to for shoulder reductions, those sort of things. Probably a little bit more than what non-EM or sort of specialty training would be. But it's got a lot of uses. Suture, I can suture a wound. I can tie a tooth together. I can use it, to get a ring off. So if you have had a problem where you've injured your finger and your hand starts to swell and you're the backcountry and you might not have a ring cutter, that's a problem. You can use it to get the ring off. So there's a lot of uses for those things. So I always encourage to try and figure out what it is. And this is really the steps, if you're going to be asked to be some sort of doctor on a trip informally, that you should consider. I mean, the major one is where you're going. I mean, if you're in the United States or not, that's probably going to be a big factor. The amount of external resources you have obviously plays a factor. But I'll tell you that weight and space are pretty big factors too. And you got to be realistic. If you've got a 10-pound med kit and you're going to go backcountry skiing, the med kit's not gonna, wherever, it's not coming with you. So a small kit that weighs less and has a few less things that's with you is worth more than the 10-pound kit that's in the car. So I always think about the common flexible things, and the biggest thing is in the space in between your ears is what's really going to be the med kit. So just for an example, this is a very minimalist. This is the one I carry when I go like backcountry skiing, or if I'm going to be light and fast for a long time. I have that little thing there is basically a homemade suture kit, a knife, and a lighter to do a few things, and some tape. And the other thing that's real nice is these emergency blankets. For their weight, they can do a few things. One, they keep you a little warm. Number two, they keep water off. And number three, they can be used as a signaling device. So that moves it out of the luxury category and into the utilitarian category for me. This weighs maybe, I don't know, it's under a pound, and it fits this big. And I've used it a few times to do different things. This is the one that actually I've created for kind of rafting. This is probably on the order of, I don't know, $500 or $600. It's got some more stuff in it. It's got airway stuff. When I'm on a raft, I don't have to worry as much about weight, and so I can carry more things. Again, I don't have a ton of stuff in there. I do have a few little airway things in case someone were to be knocked unconscious. I'm not planning to put someone on ketamine and do paralytics and stuff like that in the field, so I don't carry a bunch of that. I don't carry an AED. If someone's getting CPR in the backcountry, they're not going to make it. So these are some of the hard realities when you design these kits. If you are going and you want to be, Rescue Rick, and you like this sort of stuff, these kits here are this is what a lot of our medics are jumping out of airplanes with, military folks. You're looking at like $7,000 to $10,000 for these kits. So pretty big, but that being mostly an advanced life support kit where you could potentially intubate someone, paralytics and drugs and stuff like that, if that was what you felt like you needed to do. But I would say 98% of the time, I can get this done and or with this. And my kids know when I tell them to go get the yellow box, something's going on. They're like, okay. They don't want to be the person the yellow box comes out. So another point of this, because you guys are going to be looked toward, whether or not you want to, you're going to be asked to help in these situations. Remember that communications is a medical thing. So I don't know how many people here have one of these. This is a InReach. They make spots. They're PLBs, personal locator beacons. At this point in the rescue industry, they're almost the standard. And if you have someone that has one of these, they interconnect with your cell phone, they hit sat phones, and they give direct GPSs. People can interface with you on them. They're super useful. So I carry one almost all the time when I'm in the backcountry. I actually have one in my car just because it's Idaho. We don't get cell phone service everywhere. And the downfall is that you can send a message and it goes out and you can tell it went out, but you can't tell when it's received. And sometimes, depending on the satellites, that could be 30 minutes, an hour. Sometimes it's immediate. They can also talk to each other, which is kind of interesting, but it's not quite 100% there. Some people ask a lot of times about satellite phones. Satellite phones are decent. They tend to drop a lot, and it depends on the coverage of where you are. And so they're not a fail-safe either. And then cellular technology is obviously getting better. Obviously, I think most people use their cell phones for a lot of things, but communication in emergency situations becomes really key. And then lastly, these are just the cheap radios. I always carry these when I'm sort of like like a rafting trip or something like that. The chance of you needing to communicate frequently with someone who's not standing next to you, that maybe goes up to a ridge to make a phone call out to do something like that, is pretty high. And so this is the low tech, still around, has been around for since the 20s, and it works really, really well to have some radio. So never underestimate. This should be part of your first aid kit wherever you are. All right. So we got 5 minutes left. Is that right? Ish. 3. Okay. Okay, so if it's not a fixed flat, I'm going to hit a few things real quick because there's a few things here that people will leave this room with knowing if they really find themselves in a bad situation. So A, B, C, D for wilderness medicine. I don't know if anyone's a wilderness medicine expert here, but we go, airway, breathing, circulation, and then D and E. D is disability. Can the person walk? It takes about 20 to 40 people to hike someone out if they can't walk on a backboard. That's a tremendous amount of resources try and get mobilized. It will be hours before a rescue team can do that. It is very, very difficult. So if you can get them out of that disability to walk, or you reduce their shoulder, put the patella back in, you have saved a lot of resources and time and energy. The other one is the E is environment. So what is the environment? Day, night, thermal issues. This is going to be a big issue. If you're setting up someone to have to hike out through night, you're going to have to manage these things. So A, B, C, D, and E. That's what wilderness medicine is teaching, and I find it kind of a useful mnemonic. The other part about this is going to be aeromedical resources. So we are really lucky here in the lower 48s. If it's a day that they can fly and there's an available helicopter, we are about 45 minutes away from any sort of EMS helicopter. They are basically an ICU with rotor wings. They come with pain meds. Everyone's that I know of in the United States will fly with 2 units of blood if they're going to a scene call. And they have Jet A, which means they're fast, and they bring really experienced nurses, okay? There is nothing we can reproduce in the field, no matter how big your first aid kit is, that reproduces this thing. They are, like I said, very useful. If you in the field call as a physician, and you get on your spot and you say, I need an EMS helicopter for an emergency, and I'm a physician, they're going to figure out which helicopter and launch it towards you. They will do scene calls. You don't have to wait till the local sheriff or whoever gets there. So you can punch it on your spot, whatever, and they will start to come look for you. It's generally 45 minutes, like I said. For your knowledge, and this is something you're going to be taking care of the patient, they need about a 100 by 100 foot pad to land. Now that is variable, et cetera, but there's usually a 100 by 100 foot area somewhere around you, depends on tree canopy, these sort of things. But it may not be right where you are. And so instead of hiking the person 2 miles to the road, you can maybe hike them to a quarter mile down into the field. The other thing is that these folks do fly at night with night vision goggles. If you're in a really technical area, we are actually pretty fortunate here in Idaho because we have something called Two Bear Air, which is based out of Montana. They do technical rescue. Most of the technical ships, though, don't come with any EMS folks. So just be aware of that. They also take a long time to get there. And so if you need someone extracted by a helicopter with a hoist or something like that, there's very, very few resources to be able to do that. Most times you're looking at getting them to somewhere where the other EMS crews can get them out. That being said, I would say 80% of these significant, life-threatening, life and limb injuries are going to be flown out, and you just have to be prepared. Weather is the biggest factor. As my friend who works on a helitax says, he says, helicopters start most of the time. So there's a good chance that it won't, and we've had it all fail. So with that, we appreciate it. We want you to go ahead, be a hero. So if you haven't, you will take care of one of your friends and family in the active Idaho lifestyle. There's a couple of things, the subungual hematomas, I think the dislocations, finger, shoulder, patella, some basic laceration stuff is really good. And then fractures, of course, we didn't talk too much about splinting. The head injury, know when to send someone out, when to keep them, and then have a med kit for your mission. With that, we'll take some questions and we appreciate it. Thank you. That's my daughter after we sutured her up. She's very happy, very happy. Yes, sir.
Your recommendation regards should we or should we not take an antibiotic with us?
It's a good.
I used to take Rocephin, and I've used it at least 3 or 4 times with pretty deep laceration.
Yeah. So the question is antibiotics in the backcountry for these wounds, and Rocephin specifically. So Rocephin is actually in the TCCC guidelines. It was a Trombac critical care, 1 or 2 grams IM, and it's fairly easy to make. It hurts a little bit, so people sometimes will use lidocaine to mix it. For most, if it was a significant wound, I don't think you're ever wrong to do that. I personally would just have Keflex and oral, because if they really need that much, I think, give them a gram of oral Keflex, and then you're going to get them out if it's something that big. That's just kind of my general. It's easy to carry, and I don't have to, get a prescription other than what my wife writes for me to get from Rite Aid. So it's a little bit harder to get the IM stuff. Yeah.
There was an online question for the finger or toe block. Are you advancing the needle to the volar side? Also, I understand there's a dorsal volar nerve branch on each side.
Yeah. So yes, when you hit the bone, you're going to angle your needle up and down on both sides.
If you I would say 90% of the time you can just go straight in and get it. But yes, I usually do go up a little bit and make what's called a ring block. And so if you do it on both sides, under and over, you will get pretty good anesthesia. Jess, did you have a question? Sorry. So the question. So the question is, if you're not experienced with relocating a bone or a shoulder or patella or finger, what's the chance you're going to screw it up and make it worse, right? Is that kind of okay? Yes. So pretty low. I mean, I always consent people say, hey, you know, when I put this back in, you might have some, I could fracture it, I could, you know, knock out a nerve, I could make it bleed. I've never had that happen because the force that's involved usually will disrupt it anyway. So I would say go for it because it's really not it's not as hard as it looks. The shoulder, I think, is the most technical one. And if you watch those videos, so what I do when I train these firefighters who have no medical experience, we practice it once. I have them download the video, and then they go out. And I have not had, about every year we have 3 or 4 shoulders, maybe 2 or 3 knees. And to date, I don't have anyone who hasn't been able to put one back in the field. And these are non-trained people. They have to be a little bit more aggressive maybe than you think. It takes, if you've never relocated like an ankle, or a finger, like it's a little bit more aggressive than you think. But I have no doubt that like you'd be able to do it. And so I would say go for it. It's much better than the opportunity they have to hike out for 2 hours in pain. Yep. Yep. And series strips are great. They're actually like work really well. Actually, my daughter, that's what the ski patrol did, and that's why I took it home. I was like, oh, this looks like nothing. And I opened up, I was like, oh, whoops. The steri strips work. They actually work really well. And then the other thing, you just put you can use like a Curlex dressing or something over it. And super glue is great too. It doesn't have to be the fancy stuff, but just regular super glue is also an option. And then lastly, they make some stuff now. I mean, staples are fine. I just find them to be less useful overall for other things. So if you're not comfortable with suture, you could staple it. And then there are some they're like, if you want to go online, you can look. They're like different devices like that have little teeth in them, like staples. They're basically Band-Aids with staples, and you can put those on, and so it's kind of intermediate between the two. But yeah.
And you're closing primarily too for hemostasis. So if it's still open, it's going to ooze and bleed. So the better you can close it, it won't bleed.
So the question is like when you place a tourniquet. Yeah. When there's life-threatening bleeding. So the Stop the Bleed campaign says life-threatening bleeding. What is life-threatening bleeding? It's basically pooling blood that you can't control with pressure. It is usually somewhat arterial spurting and signs of shock in the patient. So those would be times to place a tourniquet. And we didn't talk about tourniquets here, but they're ubiquitous now on the market. I think over the counter. They're in a lot of Stop the Bleed kits, like in the schools and stuff like that. For the most part, a really good, if you clean the wound, you pack it with Curlex and a pressure dressing, that's going to get 99% of your wounds to have hemostasis. If you're placing a tourniquet, you're basically saying that you can't get the bleeding to control and stop, and you have to place it at that point. But yeah, usually life-threatening bleeding is pretty obvious. If you're soaking through multiple dressings, that's the sign of life-threatening bleeding. Place a tourniquet.
We have to stop now. Thank you so much, Dr.
Thank you.
Drew.